You can hear me?
Yes, doctor, you're audible.
Okay. But he is not audible to me. He's muted.
Am I audible? Divya?
Yes, sir.
Again, I don't understand. There is some problem of camera on my laptop. I tried to manage. I think just wait for 3 minutes more.
Good evening, sir.
Sir, good evening. Good evening. There is some technical issue with my camera. Just in 2-3 minutes, I will take
I heard it. Yeah. But you are in the minds of everybody. You are.
Yes, sir. Yes, sir.
ये आना तो नहीं है लगता ये रानी से बात मैं आना तो 2 घंटे बाद आते हैं पूरा सुन लेती हूँ
Anyway, Divya, are you ready? Unmute yourself, unmute yourself. Anyway, I think we'll have to do without the camera. No problem. I think rest of the things, it's okay. Am I audible properly?
Yes, sir.
Okay, okay. Anyway, let us start. Good evening, friends. Welcome to this our Tuesday PG Clinic. Due to some technical issue on my side, we are late for some 10-15 minutes. Please bear with this technical issue. Today, Dr. Divya from GCS Medical College is the presenter, and he has prepared the case of cardiovascular system. And I think Dr. Kashyap said, pediatric cardiologist, is going to join with us after some time. I request Dr. Divya to share his screen and start this history part.
Okay, sir.
Fine.
Good evening, everyone. Informed being mother, 14 days female child, Hindu by religion, born out of non-consanguineous marriage, residing at Saraspur, Ahmedabad, belonging to lower socio-economic class, presented with chief complaints of vomiting since last 4 to 5 days, poor feeding since last 4 to 5 days, and difficulty in breathing from last 5 to 6 hours.
Okay, Divya, can you just stop sharing for a while? I think that is important to analyze these complaints. Can you just stop sharing? Okay. Sorry, friends, my video will not be on, but I request others to keep their video on so that at least we can have the good discussion. And again, those who are having this name just DR, please rename yourself. I request at least through 4 people. Shweta, may I request you to rename this, those who are having not the name on this screen? Shweta?
okay doctor I'm trying
Yeah, please, you can rename and see that from the beginning, the name of the person should be there. You know that with the identification, we can have the good discussion and good interactions. Anyway, I think DB has started the good history part, that here the 14 days female child. And the child has 3 complaints what DB has stated. Vomiting and poor feeding since 4 to 5 days, and difficulty in breathing 5 to 6 hours. Suppose this baby is brought to you at the midnight with these complaints. What will be your thought process? What can be the issue with the child? Hitvi? Oh, and at the same time, what other information you will ask the mother? You will try to gather some details of it so that you can have some clear idea that what is the likely problem with the child. Can you take this point?
Sir, I will ask for any complaint of fever,
Okay.
cough and cold.
What is your idea?
Sir, to look for bronchiolitis.
Okay, child is only 14 days old. Child is only 14 days old. I think besides bronchiolitis, more some other problems. Your point is valid. I think fever is just important. Suppose fever is there. What does it indicate? With all the complaints, vomiting, poor feeding, difficulty in breathing, fever is also there. Suppose if it is there, then how will you take it?
Sir, it can be dehydration fever.
Okay. Dehydration fever, but why the vomiting and poor feeding? I think with this more dehydration, maybe the poor feeding. But from the beginning, some other complaints. For dehydration fever, what other question you would like to ask so that you can confirm that yes, dehydration fever is likely?
Urine output.
Urine output, yes. And sometimes there may be the chip complaint. Mother herself may complain, right? That fever is there, decreased activity. Okay, decreased activity can be there due to dehydration. But usually vomiting is not the major issue in that case. And decreased urine output. Okay, what other things you will take it? Or other information you will try to gather? What other questions you will ask the mother? With these only 3 complaints: vomiting, poor feeding, difficulty in breathing. Any further idea?
Sir, antenatal history.
I think let us go antenatal later on. First, try to focus the immediate problem. Maybe lot many information you will be able to gather later on. But for the immediate problem, you are sitting in the OPD. Patient is brought at midnight with these complaints. You'll have to act very fast to gather the information. Try to think some possible problems. And we'll have to manage the baby. Vishal, any idea?
Aspiration pneumonia, sir.
Okay. Why the aspiration pneumonia?
The patient has already history of vomiting and poor feeding.
Does it indicate it's aspiration?
No, but sir, later on developed fast breathing since last 5 to 6 hours. So
suppose the respiratory problem is due to aspiration. Then what is your explanation for vomiting and poor feeding? And that was since 4 to 5 days. Aspiration will be, immediate problem in any baby, whatever the illness is there. Okay, it can happen in the newborns. But then what is the explanation for this vomiting and poor feeding, Divya?
that may be late onset sepsis, meningitis, or maybe one
Okay. So I think that's agree that even without fever also in the newborn, and I think that is the most common problem which all of us are facing. And therefore, I think sepsis may be the first thought, is not wrong. Agree. So sepsis may be there. Sepsis can present with the vomiting, poor feeding, decreased activity, and then difficulty breathing may be the part of respiration or even its problem and complications. Okay, anything else? So this is one aspect. That sepsis, which is very common. And newborns, please keep in mind, they present with the very common symptoms, very non-specific symptoms. Whatever be the complaint, but the poor feeding, decreased activity, this will be the very common scenario in any complaint. So anything else? Okay, one is the sepsis. Suppose sepsis is thought of, you collected the investigation, blood for the investigations, and when you got it, that count is normal, CRP negative, I think which commonly we are considering for the evidences of sepsis. Even you have started the antibiotic, but these are the reports. Then how will you take it?
Sir, any congenital malformations?
Okay, what congenital malformation?
Tracheoesophageal fistula or
My question is, what is the commonest presentation of tracheoesophageal fistula? What is the commonest presentation? How they present?
Sir, presented persistent froth from the mouth and respiratory distress.
Exactly. Persistent froth in the mouth, because there is the esophageal atresia. Child is not able to swallow. And even if you give the feed and suppose to your fistula, then aspiration and pneumonia. Okay, that thing can happen. But then how will you explain the vomiting and poor feeding? In fistula, we are not expecting vomiting and poor feeding. This is possible that persistent frothing is there. But baby will be active. Otherwise, unless develop some complication like aspiration, pneumonia, sepsis, later on it can develop all the complications. That's why what is my, I will say, point to you, try to think with a given scenario. Whatever the problem is given, try to think in that direction. That means the condition which can present with the vomiting, which can present with the poor feeding, and later on even can go for this respiratory problem. Suppose the vomiting is significant, and therefore there may be some dehydration also.
CHPS may be one cause at 14 days.
Sorry, Divya?
CHPS may be one of the cause at 40 days. Congenital
Short forms I don't know.
Congenital hypertrophic pyloric stenosis.
Okay. Then the next question, what is the commonest age for the congenital hypertrophic pyloric stenosis? What is the age for it to present? Answer it, it's all right, no problem.
Around 4 weeks. 4
to 6 weeks. Usually after 4 weeks, 1 month. And in which even gender it is more common. Hypertrophic pyloric stenosis. Is there any difference in the gender?
Male, sir, male.
Male child. Here it is female. And what will be the type of vomiting? Projectile.
Yes, sir. Projectile.
Non-bilious. And mother may find that some swelling is developing on the left hypochondrium with the feeding, and with the vomiting, again child is hungry. Child is very active. Poor feeding is not there. On the contrary, vigorous feeding, because baby is hungry. So I think the idea is good, no problem. Congenital hypertrophic pyloric stenosis, but I think no point is supporting us to say. Right. Naturally, all these things will come to our mind. Then one by one we will say, oh, it is only 14 days, not 1 month, too early. Female child, it can occur, but not common. And why the poor feeding? On the contrary, child will be very active, very vigorous. Right? Child will be hungry, even crying to take the feed. On the contrary, it is opposite to that. Okay, then think something else. Let us continue. Sagrika, what will be your thoughts? Child has presented at 14 days with the vomiting, poor feeding since 4 to 5 days, and now difficulty in breathing.
Sir, firstly, there can be sepsis. It can be localized in form of pneumonia, or it can be meningitis. We have to ask the history Baby is having adequate urine output or stool output, whether the birth weight we have to compare with the current weight
Right.
because patient is having poor feeding for 4 to 5 days.
Right.
And other congenital associated anomaly which happens in syndromic like baby, whether the delivery was institutional or home delivered, and of course birth weight we have to compare.
Right. Okay, but what condition you would like to consider? One is the sepsis, agreed?
Sir, it can be in pneumonia or it can be meningitis.
Yeah, it's a part of sepsis. It's a part of sepsis.
Yes.
Pneumonia, meningitis, right? It's a part of sepsis. Beyond that. Because, vomiting is there.
Other thing is
I will give you some
GI
idea.
malnutrition, but it will not have difficulty in breathing. Baby will have vomiting and poor feeding, but difficulty in breathing.
Okay. Janmay, any idea? Suppose we thought of sepsis as I talked to you, but on follow-up or investigations, no point is supporting us to say sepsis. Like sepsis, but not sepsis, then what will you think? I think why we are stuck up. Go for some other conditions.
Sir, metabolic conditions can
Very
present.
good. Which metabolic? Yes. Why not on the contrary, any metabolic disorder, it may start with this vomiting or even the poor feeding or decreased activity. And why there is the respiration is affected in a case of suppose
Metabolic acidosis.
metabolic acidosis that may present with this problem. Okay, so I think sepsis, inverter of metabolism. Further, somebody may ask that which one it can present in this way. Okay, but any other reason, suppose female child, any endocrinal cause. Let me give the idea. Give the thought which endocrinal cause can present with this vomiting pain. Then this even due to that maybe the fluid loss, dehydration, and even the child's activity decreases, poor feeding is there. Maybe even decreases in output, and even later on the child will become breathless also.
Galactosemia.
Chenmay sir, what happens in galactosemia? What is the common presentation of the galactosemia? Why the child is breathless in galactosemia? Why the child is become this, I will say, vomiting? What is the common presentation of galactosemia? Let us focus on that. How the galactosemia patient presents. Again, it's too early for galactosemia to present. Right. Why? Idea is not bad, but I'm sure that if you go for details, you can have many ideas. Let us forget regarding our case, but the common presentation of galactosemia. Anybody? Sagrika, any idea?
Sir, poor feeding, diarrhea, vomiting, galactosemia patient can present with sepsis with E. coli.
Right.
So fever and hepatosplenomegaly.
Okay. Common presentation, if you see for the galactosemia, number one, it is due to the substance present in the breast milk, galactose. And here galactose 1-phosphate iridyl transferase, that enzyme is absent. Therefore, galactose, which is disaccharide, is not converted into monosaccharide like glucose and lactose. And therefore, galactitol is a substance, metabolite substance, which is collected at different places. And usually, at the time of birth, baby is normal, no problem. After starting the breast milk, child will get this galactose, and then the gradually disease process will start. It takes few weeks. Again, 2 weeks is too early for galactosemia. And later on, usually 4 weeks, 6 weeks, 2 months, 3 months, they may present with a persistent jaundice, for which you don't have the answer. There may be the hepatomegaly, splenomegaly. Hypoglycemia is very common for what the child is brought to you many a times. And later on investigations, you may diagnose the galactosemia. Occasionally, it's not so common, but yes, what Sagarika said, that these children are prone to develop the sepsis due to the E. coli. E. coli is common. Suppose remains undiagnosed, may present with the E. coli sepsis. And later on, you may diagnose this galactosemia. So I think that's a presentation, not the vomiting. On the contrary, persistent jaundice, organomegaly, cataract, seizures, hypoglycemia. These are the common presentations of galactosemia. So which endocrinal? I was just trying to remind you. Any endocrinal cause, and which is presenting even from the early, which can present with the vomiting, sometimes diarrhea, and then the dehydration, and then even the electrolyte disturbances. And child can have even the decreased activity, and is a part of problem or complication, maybe even the breathlessness also. And it is the endocrinal cause. That may be the sometimes full question in MD examination. Regarding that condition I am trying to remind you.
Sir, congenital adrenal hyperplasia.
Yes. Congenital adrenal hyperplasia can present in this way. The only thing, suppose if you are thinking congenital adrenal hyperplasia comes to your mind, what you will check?
Male child will.
It's a female child. It's a female child. Sagarika. So how the female child with the congenital adrenal hyperplasia will present to you?
Sir, ambiguous genitalia.
Ambiguous genitalia. So suppose this thing comes to your mind, immediately look at the genitals. And suppose female child is presented with the ambiguous genitalia, and these are the picture of vomiting, poor feeding, dehydration, decreased activity, and as a part of problem or complication of dyselectrolytemia and metabolic derangement, the child may become the breathless also. On the contrary, female child with the ambiguous genitalia, difficult to miss congenital hyperplasia, but it is easily missed in the male child. Because male child presents with a simple presentation of this vomiting, diarrhea, dehydration, dyselectrolytemia, and for what you don't have the cause, and genitals are normal, except some darkening of the scrotum, which may even you may consider normal. Anything else? So I think what was my idea, that we should have the different conditions in mind. Divya, anything further from your side? Okay, I think we can take it further. We'll come to you with this question to you later on. The question is there, but we'll wait for some time. We'll put the question at appropriate time. Okay, let us go further. Even one thing I would like to remind, sometimes, not so common, but even diabetes is also known in the newborns. Not so common, but yes, occasionally we do come across, and therefore you should keep in mind. They will also present with this dehydration, vomiting, decreased activity, and somebody does the glucose, it is quite high, even before you start this IV fluid, and therefore you may go for the consideration. Not so common, very rare, so don't speak the fast, but after this discussing the common conditions, even you can keep in mind. Anyway, you can go further, Divya, in your history.
UDP, vomiting since 4 to 5 days, 4 to 5 times per day, non-bilious, non-projectile, whitish in color, mainly contains breast milk, poor feeding since last 4 to 5 days, associated with prolonged feeding time, stopping after taking small feeds, difficult in breathing since last 5 to 6 hours, associated with subcostal retractions, respiration worsens more with feeding. But
Again, can you just stop sharing? I think now Divya has provided more information. Now with that information, how will you analyze? Because he said that the vomiting, I will appreciate, he has described very nicely, very precisely, that 4 to 5 days the duration, frequency 4 to 5 times. He made the point clear that it is the non-bilious, when it is the non-projectile. Even he had made one more point that is also good, that there is no diarrhea and such a vomiting. Second point he said, I think, regarding the feeding. Who will take this point of feeding, what he described? What does it indicate? How will you analyze? Janmijay, I think you listen to Divya with the complaints of feeding problem.
yes, sir.
What he described, first you make the point clear and then put your analysis.
So, complaints of vomiting.
No, regarding
which
focus regarding the feeding problem.
So, taking small feed,
Anyway, let Divya describe. Divya, I think people might have not noted. Can you repeat without sharing?
Yes, sir. Poor feeding since last 4 to 5 days, associated with prolonged feeding time, and child is become child taking child stopping after taking small amount of feed.
I hope that he has made the point clear. How will you interpret it? Feeding problem, that means what type of feeding problem and what does it indicate? I want the analysis of this problem from anybody from your side, some voluntary person. Try to analyze. Yes, Sagrika, how do you take it?
Sir, patient is able to take, so baby is taking breastfeeding, but the thing is, baby is taking long time and intermittently stops feeding and again starts feeding.
Right.
So there can be intermittent fatigue in process of feeding.
Very good. Yes, then what does it indicate?
Sir, it is a suck rest cycle. Matlab,
Right.
in case of heart disease, patient intermittently stops, and again sometimes patient have a forehead sweating also.
Yeah.
Feeding.
Very good.
But by this meningitis is not the cause, because patient is able to take feeding.
Yeah. So I think from this complaint now, That's a very good point what Sagrika made. I think you can distinctly say that now probably sepsis is out of question. Because child is active, right? Child is not lethargic. Yes, finding difficulty in feeding, some feeding issue, but the issue on the details of the analysis, that it takes more time. Baby is able to take the feeds, but it takes more time. That means at a time, baby is not able to suck continuously. And second point here made the clear that sucks for some time, stops even and pause for some time, then again baby is sucking. And this type of very classical story, what we say suck, rest, suck cycle, when he had described in the bracket. Now with this feeding problem, distinctly, what does it indicate? What will be your interpretation? Always, in the history, catch the point. Now from this point, we discussed many, I will say, problems initially. But now with this focus of the feeding problem, what will be your interpretation? What does it indicate? Who will take it again? That means what is your interpretation from this feeding problem? Whether it's describing the taking more time, baby is not able to suck continuously. Yes, baby sucks, but then stops for some time. Again, try to suck, and baby has to stop in between and multiple pause. This story, what does it indicate? Vita? Vita, unmute yourself. Monica, at least unmute yourself. Yeah. I think I made the point very clear, distinctly. And then I will have to say interpretation, that what is the problem with the child? What does it indicate?
Typically a suck race suck cycle.
Yeah. And where is the problem? What does it indicate? What type of the problem the child will present in this way?
Heart disease.
Yes, who said? Heart disease, very big terminology. Find out whatever the disease. Right. So try to answer precisely. Divya, what does it indicate? Come on to this point, because you have prepared.
Exertional dyspnea.
Yeah. Very classical, what we describe, exertional dyspnea in older child or adults. I would say this is the same synonymous in the newborn or in the infant. And exertional dyspnea is classically problem due to what? Janmejay? I think undergraduate student we were taught that the exertional dyspnea is the classical presentation of what type of problem? Already somebody said cardiac, so in cardiac, what problem? This is undergraduate, I would say, teaching. Please take.
The cyanotic heart.
Cyanosis, we don't know at present. Whatever the, I will say, information he has shared with us, Divya, he has not revealed the cyanosis. And how why the cyanosis, patient with the cyanosis will present in this way? Very classically, he described prolonged time for the breastfeeding cycle. Even he, I will say, identified, coined the even terminology. Sagrika, what does it indicate?
Sir, congenital heart disease in form of shunt.
Okay. I think what we should answer that this is the manifestation of cardiac failure. Reason can be anything. Still, we don't know the reason. But certainly, exertional dyspnea is a symptom of cardiac failure. And here, the way Chief Divya has described, at least we can say that it is the manifestation of cardiac failure. Then my question, Divya, to you, the question which I said that I will raise this question later on. How this difficulty in breathing developed in only 5 to 6 hours? Was it not before that? And suppose suddenly developed, then what is the reason?
The development of difficulty in breathing developed just before 5 to 6 hours of admission.
Yeah. Anybody would like to elaborate on this, my question? That what Divya said, that 5 to 6 hours problem only. I'm sure that mother must have complained. I agree with him. But I will say the clinician, how you will go further? That means, is it so that the cardiac problem develop in 5 to 6 hours only? And therefore child become the breathless. This is the real beauty of the history taking. Naturally, I'm sure that what Divya has mentioned in the history, mother must have complained of. And I'm sure that this difficulty in breathing must be the serious problem. That's why child is brought to the hospital. But really, what we discussed initially, that circulatory cycle, which is indicating cardiac failure, and in the case of cardiac failure, breathlessness is problem of the feeding problem is 5 to 6 days, and difficulty in breathing only few hours. So here, as a clinician, what you will suspect, or retrospectively, what you will try to confirm from the mother. Anybody? Divya, yourself, are you able to think now retrospectively? Suppose if it is cardiac problem, it has not developed, I will say, just within few hours. Right? Manifestations, even the manifestations must have started before this. Probably maybe the part, this even the vomiting and poor feeding also may be the part of it. But then why the breathlessness only 5 to 6 hours? I think here, what is my point? Mother might have complained of 5 to 6 hours, but if you ask her whether the respiration was totally normal before 5 to 6 hours, then she will say not normal. Child was breathless. That means, you can ask the abdomen that whether the abdomen was moving with its respiration fast. Mother, I'm sure mother will say yes. But within 5 to 6 hours, the severity might have increased. Because we know that whatever the cardiac problem leading to the cardiac failure must have manifested even before the problems of vomiting and poor feeding. Even before this vomiting and poor feeding. The only thing that it may not be that serious or the significant, and therefore mother may not complain. But if you ask the mother whether the child was taking the normal respiration or fast, then I'm sure she must have, she will commit that it was fast, but now it has become this increase. The problem is, the 5-6 hours breathing problem not convincing us the cardiac problem. Must be, I will say it has increased, but before that. And in such patients, we'll have to go retrospectively the history part. And then our story will be changed. So that's the point, that how in the exam also, you should even go. You can say even here that mother complained of 5 to 6 hours, but when on details inquiring and interrogation, mother mentioned that this, at least the breathing problem was there even before this poor feeding and this vomiting. Right. So that's the point, that how we should take it. Because, he has very specifically mentioned, Divya, I will appreciate his history taking. He has paid the attention, I will say, to each point. The difficulty in breathing and more so while taking the feeds. That means it very precisely he has mentioned that they are gestational dyspnea. Okay, good. Now we can go for further. What was my point? Then the history point, take it properly. Once you come to know, go retrospect in details of the history, and you can put even in that way that mother said 5 to 6 hours, but with the further interrogation, she stated that at least the breathlessness problem of breathing was there before the problem of poor feeding, or she will put out some days, 7 days, 10 days, something she will say. Right. Okay, Divya, now we can go for further history.
So child is of 14 days. So I will start with birth history. Antenatal history. Maternal age was 26 years. Active married life for 6 years. Gravida 2, para 1, and live 1, live child. LMP was 20 December 2022. EDD was 27 September 2020.
Sorry, Divya, for interruption. You said gravida 2. And parity 1. And living 1. Abortion 0. So where is the mathematics?
Sorry, sir. Live is 2 now.
Okay.
I had not counted this child.
So I thought that something is wrong. Now you can modify it the way in which you wish.
P2, L2, sir.
Okay.
Spontaneous.
Please, again, if I remind you, here I think as an examiner or something, discussion myself is there. Srinivasan sir is there, but sir is silently observing us. But in the exam, long case, 6 examiners will be there. So 6 multiplied by 2 means 12 eyes will be there. And 12 eyes and 6 minds. And opposite person is only 1. I understand. Just demanding that, so many things people will note it. So be very, very careful. Don't give the, I will say, small point to the examiner for discussion and to waste the time. Anyway, go further. Good.
In its conception, booked at gestational age of 6 weeks, antenatal checkups were done, 7 visits were taken, antenatal USG was normal, tetanus toxoid immunization 2 doses taken, and
again, Divya, please keep in mind, we are discussing the past also. Now, no tetanus toxoid is there anywhere.
Okay.
Either it is a TD or TDM.
Yes. Okay.
I think the government or corporation, suppose mother is given, it must be the T small t. And even some private sector, somebody might go for the TDEP. Ideally, TDEP is desirable.
Yes.
And somebody may ask the question, Sagrika, why this TDEP is desirable? I asked that it is desirable, why it is so? Suppose pregnant mother comes to you and she has no any problem of affordability. She will say that you go for the best which is possible for me. Then what you will go for TDEP? Why? What is your idea?
Because the diphtheria.
Sorry, I think there is some net issue. Can you repeat it?
to cover the diphtheria.
Okay. But then why this P, small p is also there? And therefore diphtheria, T small d is there. Then I think TD is sufficient. Where we are going for pertussis also. You know, the government, they are giving the T small d. That means tetanus and diphtheria toxin. That's why I'm asking this question, because commonly people are going to ask you. Because now the practice is T small d in the government and the corporation sectors, where probably cost is the issue. So for that is for the public health. But in the private practice, where the affordability is not the issue, we should go for TDAP. And the question will come that what is the idea of including pertussis component for the mother? Vishal? Divya? On the contrary, I thought that this is known to you, but somehow it reminded me that let me check. Please keep in mind, you know, pertussis can develop even to the adults. We have the concept that usually adults don't have the pertussis, but no. On the contrary, they are reservoir for the pertussis bacteria, organism. And what happens that sometimes, and you know, the pertussis newborn is not getting the protection. For others, suppose newborn is getting some protection. But for pertussis, there is no antibodies transmitted through the placenta from the mother. And therefore, baby is not getting much protection. And in short, pertussis is known in the newborn. And pertussis in the newborn is having more problems, complications, like even these apnea, cyanosis, feeding problem, dehydration, not many issues. And it is even the life-threatening condition. So prevention is better. And therefore, we give the pertussis component to the mother. Mother's body, there will be the pertussis antibodies. And these antibodies can be transferred to the baby, and baby can get the protection. For that reason, we go for the TDAP to protect the baby from the pertussis. Indirect, I will say, modality. Even one more point with this reference, you know that in the USA, particularly our grandparents from India, when they go USA to take the care of their grandchild, newborn grandchild, it is mandatory that you should have received this TDAP. The reason is that means at least you will not transmit this pertussis to the baby. And this is the reason, in short, that pertussis is more problematic, more serious, life-threatening disease in the newborn, which is known. So prevention is desirable. And therefore, for prevention, we go for this TDAP to the mother. So mother will also get some protection from the pertussis, and the antibodies can be transmitted to the baby and it can be protected. And for the same reason, the TDAP is, I would say, mandatory for the grandparents visiting USA to take the care of their grandchildren. Right, I think point is clear. So TD and TDAP, not tetanus. Even one more vaccine. In the prior practice, one more vaccine. During pregnancy, I'm talking. Beside TDAP or TD, any other vaccine which is recommended? With influenza vaccine. Influenza vaccine is also recommended during pregnancy. The reason is, you know, by chance the mother develops the influenza during pregnancy, complication rate and mortality is high. So that is for the protection of the mother during the pregnancy. So I think these vaccines we should know. Being the pediatrician, we should be aware of it. Anyway, Divya, you can go further. Go ahead.
No history of fever, PH, hypertension, heart disease, gestational diabetes or diabetes, hypothyroidism, epilepsy, and SLE, urinary infection, drug intake, addiction, TB, blood transfusion, bleeding or leaking PV. Mother blood group was A positive, HbA1c, and HIV were non-reactive and negative for torch titers. Natal history, full term 37.6 weeks of gestation, delivered by normal vaginal delivery, cried immediately after birth. Birth weight was 2.9 kg, appropriate for gestational age, female child, amniotic fluid clear. Apgar score was 9/9, delivered at hospital, no gross congenital anomaly. Postnatal history.
I think here also one more point. Anybody would had noted it? Would you like to point out anything in the natal history? Anybody? Vishal? I hope others are also there.
Sir, Tom 37.6 week of Tom baby.
Okay. Okay, he has mentioned full term baby. No problem. Anyway, last point. Let me come to the point. Divya?
Yes. Postnatal history.
No. I think last
No gross
point.
congenital anomaly.
No gross congenital anomaly. And I think you are discussing some cardiac problem likely. And it is not the gross anomaly.
No gross external gross congenital anomaly.
So best way, again, why we should ultimately, what will happen? Some exams will remember that you have mentioned not gross anomaly. And when you are discussing congenital heart disease, examiner will say that you are already said no gross anomaly. And this is not gross, it is not the minor, right? And then unnecessary discussion will take place. I think if at all, what you can mention, no obvious congenital anomaly. I think it may be the hidden. Obvious, at least it is not there. It was not there at the time of birth.
Yes.
And cardiac malformation is possible that suppose ventricular septal defect may not be having manifested at the time of birth. Later on it can manifest. But then what? No obvious. That means on examination, it was not clearly seen. Okay. This is exam point of view, and I think we should be careful. Okay. Go ahead.
Postnatal history.
I think again, Apgar, 1 minute, because you have mentioned. Can you just stop sharing for a minute? Because again, this is the common issue which the people are taking in the exam. Who will take the Apgar? Suppose newborn case is there or something is there, people are going to discuss. Yes, anybody? He has mentioned Apgar 899. Even what you mean by it? If you unmute yourself, you mentioned 8/9/9. So what do you mean by it?
Apgar at 2 minutes, 5 minutes, and 10 minutes.
So first Apgar at 2 minutes.
Yes.
And second Apgar at
5 minutes.
And third Apgar at
10 minutes.
And what is the importance? Why we go? Sagrika, is it right what Divya said? 2 minutes, 5 minutes, 10 minutes?
1 minute.
Yeah.
1 minute.
It is 1 minute. Even Vishal was also, he is your friend, so nodding the head, but he didn't speak. So Apgar 1 minute, 5 minutes and 10 minutes. What is the importance of 1 minute, 5 minutes, 10 minutes? Why we go for the 3 times Apgar? Once you said 8, it is okay, fine. What is the importance of 1 minute, 5 minutes, 10 minutes?
Sir, because in some patient, 5-minute Apgar or 1 minute Apgar is less, but 10-minute Apgar, if it is good, it is not severe birth asphyxia. If 10-minute Apgar is less than 5, then it is severe birth asphyxia.
It means, Sagrika, suppose 1 minute Apgar is good. Is it necessary for me to go for 5 and 10 minutes?
Yes, sir.
Even the first 1 minute is good. Still,
Because 5 and 10-minute Apgar can go down also.
so initially good, but later on can go down. That's good. That means even the first is good, but still go for 5 minutes and 10 minutes. Then what is the importance? What does it indicate? 1 minute, 5 minutes, 10 minutes Apgar. What is its significance? What does it indicate? What idea you are getting? Divya must be thinking that I have prepared the case in some other way, and sir is taking literally. But I think I want to convey the message to even all the students also. It happens. I remember in last exam only, one of our candidates saying, she said that nothing was asked pertaining to her case. Nothing even, not a single word. And it can happen. The point is, I think, examiner wants to assess whether you are aware of all these issues or not. Anybody is having idea why we go importance of 1 minute Apgar, 5 minute Apgar, 10 minutes Apgar? I think 3 components. You must be knowing 5 components, and then scoring. Because this is very important. Apgar, Moro, in the exam newborn case, they are going to ask you. Even suppose resuscitation table, they are going to ask you to Apgar. Anybody? Whatever you know, no problem. Whatever you have the idea, you can just share. Sagrika,
Sir,
what is your idea? Yes.
Sir, Apgar is having 5 components, and each component is given the score 0, 1, 2.
Right.
First is appearance. If full central and periphery both are blue, then it is 0. 1 means central is pink and periphery is blue, and 2 means whole baby is pink. Then appearance, then pulse. 0 means no pulse. 1 means pulse rate is less than 50, and 2 means less than 100, and 2 means above 100. Then third component is grimace. 0 means no grimace, 1 means some grimace, 2 means grimace, spontaneous activity is present.
Yes,
and
vigorous grimace.
Vigorous activity is present. And fourth is activity. 0 having no spontaneous activity, 1 some activity of limbs, and 2 means spontaneous active baby. And fifth component is respiratory effort. 0 means no spontaneous respiration, 1 is breathing but with labor, 2 is normal spontaneous respiration.
Good. At least the 5 components scoring she has given. From this, my question that what is the importance of 1 minute score, 5 minute score, and 10 minute score? Suppose 1 minute score is bad. That also interpretation you should know. I think 7 is the cutoff for not good.
Less than 7 is considered bad.
Which one, Divya?
Less than 7 is considered poor.
Yeah, I think I remember the figure is 7.
Yeah.
So suppose if it is in some newborn, it is 6 or 5. 1 minute Apgar, then what is your interpretation? How will you take it? What does it indicate? I think this is very basic question, and which the people are going to ask you at least in the
Need of,
exam.
Sir, initially, some baby have more time to have proper cardiorespiratory function to be established.
Right.
And all the baby will not be peeing at 1 or 2 minutes. So that's why we need to check them for 5 and 10 minutes.
Okay. The point is which I wanted. The 1 minute score indicates the severity of asphyxia. Poor the score, more of the birth asphyxia. That will give you the idea that what management part will be required in this baby. Suppose very poor, sometimes immediate intubation. That if you see even the resuscitation algorithm, and in short, 1 minute score gives the idea regarding the severity of asphyxia if it was there. If it is there or not, from 7. And if it is there, then severity. But 5 minutes Apgar gives the idea that what is the neurological outcome of the baby, likely neurological outcome. Because for 5 minutes, suppose if it is the poor Apgar score, that means likely it has taken the damage to the brain, and in the future, neurological complications or sequelae is more expected. Baby may survive, but still. And suppose still the 10 minutes, when the Apgar score is bad, that even gives you the future neurological again, that what is going to be the status of the baby. And here gradually the people are coming to the point that in this group, how many babies should be supported? Because at 10 minutes, suppose Apgar score is poor, that means significant neurological damage has taken place. So the point is 1 minute Apgar is for deciding the severity of asphyxia and plan for the management of the resuscitation. And 5 and 10 minutes for assessing the likely neurological damage and neurological outcome in the future. That is the purpose for this Apgar, 1 minute, 5 minutes, and 10 minutes. Suppose if you know everything, that somebody will ask, who was the Apgar? Anybody has any idea? Who was Apgar? Pediatrician? Obstetrician? Or some other specialty? Apgar herself, she was anesthesiologist. And Apgar, the name is derived from her name. And this mnemonic, what even Sagrika was describing, that is APGR, Apgar, is from this appearance and grimaces and all these 5 points like that. Anyway, somebody is going to ask you. And anyway, this was the idea that in the history, from the exam point of view, keep in mind that they can ask you anything. Anyway, Divya, you can take it further. Actually, Divya has taken the history very nicely. Very few points are there, but whatever the points are there, good for the discussion.
Neonatal history. No history of NH admission after birth. No signs of respiratory distress after birth. No history of neonatal jaundice, neonatal seizures, or neonatal hypoglycemia. Breastfeeding initiated within 1 hour of birth. Other secretions are adequate and baby is taking feeds well, followed by
I think,
birthing.
Divya, just I will suggest you, can you take this point and what is your probable reason for mentioning that point? So that it becomes, I will say, we can save the time. I think NICU admission, obviously, that NICU admission indicates some perinatal insult, and then neurological problems can be there. For this reason, it is good. Respiratory distress after birth. What was your idea, Divya?
Sir, respiratory distress may be just after birth if patient has tachypnea or low saturation, but there is no issues like that after birth.
Right.
Then for seizures and jaundice, there is no admission for jaundice. So patient had no any abnormality.
Anyway, I think suppose somebody asks you here, you can say that this is a very common neonatal problems. And if at all it is there, they can contribute for this further pathology or disease to the baby. For this reason, suppose you know the jaundice is there, even already we discussed in a case of galactosemia, some neonatal seizures, maybe hypoglycemia, or even neonatal hypoglycemia, it may be due to several conditions. So absence of all these points helps you that it was not there, right? So you can give the explanation. Very good.
Baby passing urine 8 to 10 times per day and stool 4 to 5 times per day, which was greenish in color.
Good.
Negative history, no history of cyanosis, no history of fever, no history of failure, no history of convulsions.
Again, give this one line answer. Your idea of asking this negative history.
Sir, asking for central cyanosis like oral mucosa is cyanosed or not, which can lead to high suspicion of congenital heart disorder.
Right.
Sir, asking for field to rule out late onset sepsis. To rule out the late onset sepsis. Sir, for convulsions and sir, any hypocalcemia, hypoglycemia
yes, okay.
Not there leading to convulsion. Sir, no history of prolonged jaundice due to ruling out, sir, any congenital heart disorder associated with icteric component. No history of any surgery.
Which prolonged jaundice will be associated with heart disease?
Sir, like LGL syndrome or
okay, so some syndromic condition.
Yes, sir, some associations.
Okay.
No history of bottle feeding, which can
surgery,
lead to
surgery.
Sir, surgery may be any
here my idea is don't invite the trouble.
yes,
we should mention unnecessary with the surgery. Right, in 14 days old child,
yes,
surgery might have done somebody, right? And how it is related to my problem. So something is there, it's okay, you can mention. If it is not there, don't mention unnecessarily, right? Bottle feeding okay from infection and rapid formula. What is the rapid formula?
Sir, any formula feeding is not given.
You said rapid formula.
Sir, it may lead to NEC like complication, which may also present like vomiting and
okay.
And sir, cow milk injection, same reason, cause of Tom NEC.
I think here, what is the best way to mention only breastfed child? If you speak, I think the other thing has gone.
Okay, sir.
The bottle and formula and cows and everything is gone. Because my one line clarifies everything. If I say only breastfed child, that's all. Right?
Yes.
Okay.
Past history, not significant.
Again, what is not significant and significant?
Sir, in 14 days, there is nothing significant.
In 14 days old child. So again, what is my point? That mention it very appropriately.
Yes.
Right. Okay.
Sir, family history. 26.
Somebody will ask me, in this way. 14 days is the total duration. Then what is going to be there in the past? Because life of the baby is 14 days. Am I right?
Yes, sir.
Now in the 14 days of life, what is going to be past? Everything is present.
Yes, sir.
Right. Okay.
Family history, no consecutive present. Baby is second by birth order. No history of similar illness in sibling. No history of congenital heart disorder in sibling and both the parents. No history of sudden death or unexplained death in family. No history of facility and phenylketonuria in mother. Immunization.
One minute. I know even in the exam also smartly go rapidly. If no, because unnecessary somebody may catch it. But examiner, if it's sharp, then he will say, oh, please, come back. I think here some of the points, Divya, because you have taken the good history, it requires clarification from the exam point of view. You said no history of CHD in sibling or both the parents. Then the question may come, suppose one sibling is suffering, then what is the incidence of CHD in the next sibling? Suppose mother has suffered the CHD in her childhood, what is the incidence in the offsprings? And what is the percentage with the father even? So these points people are going to ask you, and these points are there. Bolo.
Sir, if one child is already suffering from CHD, there is 8% risk of 2 to 8% risk of chances that another child will suffer.
What is the incidence of congenital heart disease in general population? In general population, what is the prevalence of the congenital heart disease? Any idea? Probably, Divya, this is the figure what you said, that is for the prevalence, 8 to 10%.
Yes, sir.
It is in the general population.
Yes, sir.
And with this one sibling, it will increase. What percentage? On the contrary, one of the discussion I was doing the pediatric cardiologist, they said that, sir, now these are the old figures. With this modality and diagnostic facility, the incidents are increasing. But still it comes in the, I will say, he said that in the textbooks, this is all right, 8 to 10%. And with the one sibling, what is the percentage in the next sibling? Any idea? Have we read? If you are not ready, you will not remember. Naturally, these figures are like that. Sagrika, any idea?
No, sir.
Okay, please check it. In the exam, this will be useful. And I will not speak the figure because students should not remember the wrong figure. So there is something is there in my mind, but I will not. I will request you to verify it from the book. And what is the particularly from the mother? Suppose mother suffered from the ventricular septal defect, even the VSD was repaired in her childhood, but still incidence of the congenital heart disease in her offspring is there. And what is that figure, Divya?
Not that.
And once we mention in this thing the history, some examiner is going to ask this question. Related to the sibling, related to your, I think it is 25% or so.
To 30% risk of developing, but not
maybe 25-30%. Anyway, I think with the father it is less. I don't remember the figure, but please check it. And sudden death and unexplained death, What are the common causes of unexplained death, neonatal deaths, stillbirths of unexplained deaths? Suppose the bad obstetric history, some mother lost even the unexplained multiple deaths, then what causes should be kept in mind? 3, 4 most common causes. This is again, people are going to ask in the exam. Please keep in mind, one is the diabetes mellitus. Second, you the RH incompatibility. Even the congenital syphilis and incompetent os to the mother. These are the 4 most common causes for the multiple neonatal deaths or unexplained deaths. You mentioned the SLE and phenylketonuria in the mother. So I don't know whether you want to give the answer or you have invited the trouble. Suppose mother is suffering from SLE, then what problem can develop to the baby?
Complete heart block.
Okay, and phenylketonuria?
Sir, congenital heart disorders like PGA and VSP are more common when mother is suffering from phenylketonuria.
Is it? You are guessing or having the idea? What are the common manifestations of phenylketonuria? In the baby.
Asking baby.
In the baby I am talking.
Neonatal seizures may be present.
Okay. Please remember.
Sir, hypoglycemia.
Yes, Divya, you can carry on, please. Please remember the very prominent features for phenylketonuria. Number 1, the baby is going to be low birth weight. And second point, very important, the macrocephaly. Even the intellectual disability. And of course, congenital heart disease, you are right. Which one I don't know, but in phenylketonuria, congenital heart disease is known. Maternal phenylketonuria. And then the baby will be IGR, intellectual disabled, macrocephaly, and congenital heart disease. And even the sometimes hairs, light colored sparse hairs. Anyway, what was my question? That whenever you mention such points in the history, you should be prepared that somebody is going to ask you the question. So come with that preparation. Of course, if you mention that, it's very good. Definitely. Please go ahead.
Immunization history. Birth vaccines were given. OPV, BCG, Hep B, injection vitamin K given at birth. Dietary history, breastfeeding initiated within 1 hour of life. Babies on exclusive breastfeeding since birth. Breastfeeding was given every 2 hourly and on demand from birth till 10th day of life. Then baby had developed vomiting and poor feeding since last 4 to 5 days. Summary.
This feeding history in the newborn you have taken very rightly, very good. When the breastfeeding started, on which schedule she is following, all these points you should mention. Very good. Okay.
Summary. 14-day-old female child presented with chief complaint of vomiting, poor feeding since last 4 to 5 days, and then developed difficulty in breathing since last 5 to 6 hours with uneventful antenatal, natal, family, and immunization history. A raised probability of late onset sepsis, undiagnosed congenital heart disease at birth, aspiration pneumonia, and any anatomical GIT conditions. General examination.
What is your idea? Undiagnosed, that means somebody missed the congenital heart disease.
At birth, sir.
Yeah, but at birth, that means somebody had missed it.
Yes, sir.
It is the allegation to the previous pediatrician. Somebody has missed it. That's why, that's why you can say that the possibility of congenital heart disease. And some of the heart disease, you know, what is the definition of congenital heart disease? Anyway, I think we'll discuss when you go further. Now go on examination, because I will have to keep in mind, you know, today, if you see, I think we started 20 minutes late. If you consider 1 hour and 20 minutes, we have discussed only the history. And that credit goes to Divya, because he has taken the very good history. I would say mention many points, which even that can be asked you in the exam, and you should be prepared with answer to all these questions. I'm sure that if this type of the case is there, and you mention all the points, and some scattered, these are the questions you may face, and if you answer quickly, that will create the good impression. So you should be prepared. I think all these incidents and other things which we have not answered, please find out from the books, because I do not want to give the wrong figures. Precise figure that what is the incidence of CS being the prevalent in the society or community. That is the incidence when the one sibling is suffering. What is the incidence with the mother and father to her offsprings? And some other points which I think we have discussed in length regarding all the vaccines and other aspects. Okay, go for the examination.
General examination. Baby was examined under full daylight after taking full aseptic precaution. No facial dysmorphism, no pallor, no cyanosis, no polycythemia, no icterus, no clubbing or edema.
Divya, I understand this goes reflexly, but we should keep in mind. On one side, you said no pallor. Other extreme, you mentioned no polycythemia. Do you expect the pallor and polycythemia to gather in one baby?
They're not together, but maybe one can have pallor or polycythemia.
Okay.
Separately, sir.
Good.
In
the 14 days old baby, do you expect the clubbing even in the cyanotic heart disease? Right. So what is my point? Yeah, not less likely, not even possible.
Okay.
If you ask any pediatric cardiologist, even have you seen the clubbing, even suppose severe cyanotic heart disease? Then also, because clubbing takes more time to develop clubbing. Very few conditions in weeks, even bacterial endocarditis, it can develop the clubbing. Lung abscess, yes, that also requires minimum 4 to 6 weeks. That infective endocarditis, lung abscess, yes, they can develop within short time. That is few weeks, 4 to 6 weeks. Otherwise, it requires even months together. Right. So I think 14 days baby, this is not to mention the clubbing, even in a cyanotic heart disease. Right. Okay.
Tachypnea was present. Head to toe examination. Head Iap open at 12 and normal. Eyes were normal. Oral cavity and tongue normal. No natal tooth, no tongue tie. Chest normal. Bilateral symmetrical expansion. Abdomen.
I think here in the eyes, better to mention no cataract. You know, subthird points positivity. Suppose congenital heart disease, and if you say no cataract, at least rubella is less likely as an etiological factor. It does not exclude, but less likely. Right. Okay.
Abdomen soft and non-distended. Genitals normal. Limbs normal. No gross congenital anomaly. Anthropometry. At birth, weight was 2.9 kg. At 14th day of life, weight was 3.1 kg. Length at birth was 49 centimeter. Length 14th day of life was 50 centimeter. Head circumference was 34 centimeter. And 14th day of life, head circumference was 35 centimeter. Chest circumference was 31 centimeter at birth and at 14th day of life.
I think solve question for the exam point out. When you will call it is the birth weight. When the weight is taken, you can say it is birth weight. That means timeline.
Sir, within 24 hours before
Very
the
good.
fluid loss occurs.
Very good. Suppose second day, third day is not birth weight, but first 24 hours. And when the head circumference should be taken? What is the appropriate time for the head circumference?
After 2 to 3 days.
After at least 24 to 48 hours. Why?
Because of caput and cephalometoma.
Yeah. That whatever the changing in the skull has taken place, let it settle down so that you can get the real head circumference. Okay, go ahead.
Systemic examination, abdominal system inspection. Abdomen is non-distended, normal abdominal thoracic movement. Umbilicus central place slightly everted, no discharge from umbilicus, no visible pulsation. Hernial orifices, groin, genitals, and inguinal regions were normal.
Here for a small question. You said abdomen is not distended to previous slide.
Yes,
but suppose newborn abdomen is scaphoid.
congenital diaphragmatic hernia.
Okay. There is no congenital diaphragmatic hernia, but abdomen is scaphoid. And there is not this breadless, scaphoid abdomen and breadlessness diaphragmatic hernia. Scaphoid abdomen and bilious vomiting.
Urinary atresia.
Very good. Very good. It is duodenal atresia. Because nothing is passing beyond duodenal atresia, and therefore bilious vomiting and scaphoid abdomen favors duodenal atresia. And breadlessness and scaphoid abdomen favors diaphragmatic hernia. Okay, go ahead. One more point, I think somebody is asking that umbilicus should be cut and numbers of vessels should be noted in your case paper. Now it is routine that while cutting the umbilical cord, numbers of vessels should be noted in your case sheet. So that single umbilical artery and all these things should not be missed. Many times we don't know. So this is also in neonatal examination. This point should be kept in mind. And Sagarika, how much the umbilical cord should be kept long?
Sir, at least 2 centimeters from the abdomen.
And why not less? Why not too long?
Because if we require to put a catheter for any reason.
Anything else? So any complication can develop. Suppose if I cut too closely, that is the main point. At least 2.5 centimeter. Please remember 2.5 centimeter away from the umbilicus. And the reason is if you cut too closely, there may be sometime vital intestinal duct, and then it may develop the fistula. Sometimes there may be the urachus, then urinary fistula. So to avoid these problems and complications, at least 2.5 centimeter away from the umbilicus is recommended to keep the length of the cord. Okay. Just go ahead. Divya.
Palpation, superficial palpation, soft and non-distended, no palpable masses. Deep palpation, liver palpable, 1 centimeter below right coastal margin, mid-clavicle line with soft consistency and smooth surface. Percussion, dull note is noted from right fourth intercostal space. Liver span was 6 centimeter. Auscultation, bowel sounds were present. Respiratory system, nose, mild nasal pharynx.
I'm not asking you the newborn, but older children. What is the normal frequency of the bowel sounds?
20 25, sir.
Yes, sorry, Sagrika, what did you say?
Sir, 20 to 25.
Okay. Normal, I'm talking of normal, HV. I request you to check it. And what is the bowel movement for the small bowel and large bowel? Somebody may ask in this way also. Small bowel, 8 to 10 times per minute, and 4 to 5 frequency of large bowel. Okay. Divya.
Respiratory system on inspection, nose, mild nasal flaring was present. Subcostal retractions were present. Trachea lies in midline, no external deformity, no asymmetry of chest. Palpation, trachea central placed, bilateral symmetrical chest expansion. On auscultation, bilateral entry present and equal. Bilateral chest sounds clear, no additional breath sound. CVS, on inspection, no apical impulse seen, no visible pulsation over neck and precordium. On palpation, apical impulse in left fourth intercostal space, just lateral to midclavicular line. Left parasternal lift, grade 2 is palpable, no palpable sounds. Auscultation, heard sounds audible at apex, slightly loud, S1. S2 was heard at upper left sternal border, single S2, which was loud. S3 was present, followed by short mid-diastolic rumbling murmur. No S4 is heard. Mitral area, mid-diastolic rumbling murmur present. Tricuspid area, no murmur. Pulmonary area, pulmonary ejection systolic murmur was present. Gibson area, continuous murmur was present. Aortic area and auscultation of over infraclavicular region, back and right and left axilla. There were no murmur in investigation.
Hey, can you just stop sharing? I hope Pita, the Dr. Kashyap has joined. Pita, any idea? Okay. Any suggestion to Divya from other friends for systemic examination? Good suggestion, I would say. Not any suggestion, good suggestion. Which system should be examined first? Which was your targeted system?
CVS, sir.
Then CVS should be first one. Am I right?
Yes.
So in the exam, don't do the small mistakes, because always once you come to know that this is likely, and in suppose multiple systems are involved, sometimes it may happen that the cardiac problem, respiratory problem, multiple, then the whichever it has having the prominent presentation, that should come first. Suppose in a case of sarcoidosis, you will get the respiratory problem, you will get the cardiovascular problem, you can get hepatosplenomegaly also. But mainly presentation will be of respiratory system. Breathlessness, cyanosis, clubbing. Then I think respiratory system should be examined first, then the cardiovascular system, and even later on you can go hepatosplenomegaly and other things. So that is small point but important. Okay. Now, whatever the CVS findings he has put it, anybody can summarize cardiovascular findings? Only positive finding. Whatever he described, only positive findings on cardiovascular. Suppose inspection, whatever positive, palpation, percussion, auscultation. And even some points in general examination related to the CVS. Anybody can take voluntarily. Chandrachak, can you take it? Whatever point you have noted, Even I would suggest one point that those who are attending, please perform the habit of putting the positive findings on your paper so that you can have a clear idea that what problem is likely with the patient. Anyway, Divya, I think you yourself you can take it because now we don't have much time, but we will take these findings in detail. What are the positive findings on general examination related to the CVS and positive findings on cardiovascular system proper?
Sir, on CVS examination, on inspection, there was
Any point related in general examination?
only sir tachypnea was present on inspection.
Okay, I think what was the heart rate?
Heart rate was sir around 160, 180 sir.
180 you mentioned. Is it normal?
No,
By definition?
no sir. Vitals, sir, sir, it's like sir.
So I think you can mention that there is the tachycardia, there is the tachypnea
Tachypnea.
with the endroins, nasal flaring,
Hmm.
right? And what are the SpO2?
SpO2 was sir 86% on room air and
That is
91% on 91% on O2 with nasal prongs, sir.
So what is your interpretation for the SpO2?
Sir, presence of hypoxia, sir.
Is it how will you take it? Hypoxemia? From the SpO2 point of view, when you will say normal, when you will say hypoxemia, and at what level the clinical cyanosis will develop. With SpO2 level I'm talking.
Less than 85% of SpO2.
Very good. With the less than 85% by pulse oximeter SpO2, that means clinically there may be the cyanosis. It is clinically detectable cyanosis. I think here with this 86, clinically you have not mentioned, then what can be the explanation? Okay, that is number one. But that means significant. Even with the supplementation of oxygen also, it has come to only 91. So what does it indicate? Regarding etiology point of view? Sagrika, what will be your comment?
Sir, cardiac.
85, 86 with SpO2 with oxygen also, it has come to 91.
Yes. Cardiac more likely.
Sorry, Sagrika, I think your net issue. Can you repeat it?
Sir, of O2, if the respiratory condition is there, it should be corrected.
Yeah.
In cardiac, it is not corrected with oxygen.
So I think here, even this still 2 liter probably may not be the good flow, but still it does not get much corrected. So you may think, and with this, even the respiratory manifestations are not that bad, which will go so hypoxemia. So in the absence of even the significant or severe respiratory manifestations, with this low SpO2 not corrected by the oxygenation, that indicates that basically maybe the cardiac cause. And that cardiac cause may be in the form of some cyanotic condition. At least you can suspect. So interpret even all these findings properly. Now CVS proper, Divya.
On CVS examination, on palpation, left parasternal lift grade 2 is palpable. Apical impulse set left post
That
intercostal
left
space.
parasternal uplift, what does it indicate? First, I think anybody can demonstrate at least online that how will you try to see? Because this is important. Somebody is going to ask you in the exam. Janmejay, can you describe and try to at least show that how will you try to see for the left parasternal heave or uplifting?
So, at the lower end of the patient, and we see through the
By the lower area? Divya, any idea to you? Suppose here we are discussing online, but patient is there. Any examiner is going to ask you for demonstration. Sagrika, any idea? For left parasternal heave?
Sir, we have to keep our hand over the parasternal area and feel the any heave.
Okay, which part of the hand?
Ulnar side, sir.
Yeah. I think here I am off the video, so will not be able even to show my hand. But you know that you can take your right hand and ulnar border of your right hand, put on the left parasternal region and see that how much it is lifted with this cardiac contraction. And that will give the idea. Is there any grading, Divya, for this uplifting?
On inspection, we have found
No,
that
on palpation, I'm discussing palpation. Is there any grading?
if we only appreciate on palpation, then there is grade 2. If we can also appreciate on inspection, then it will be grade 1.
This is in a lighter mood, I will say this is Divya's grading. You know, left parasternal heaving, how the grading. If you are able to demonstrate rightly, then they will ask. As I said, you can palpate with your ulnar border of hand on the left parasternal region. Suppose if it is just you are feeling, that is grade 1. And grade 2, you feel, and even if you press it, it is compressible, that means disappears.
Yes, okay, yes, sir.
That is grade 2. And grade 3, even if you feel, if you compress to not to feel, but still it is palpable. That is grade 3. I hope that point is clear.
Yes, sir.
Right? Just you feel it, grade 1. You
Mm-hmm.
feel and you press it and not felt, grade 2. You feel, you press it and even still it persists, that is grade 3. And what is the cause for this left parasternal heaving? What does it indicate? Which which part of the heart is affected? No, ultimately, this interpretation is important.
Right ventricle hypertrophy.
Yeah. But you know, I think here, very cautiously, Divya, you should speak. Because only 14 days, usually the right ventricular hypertrophy requires more time to develop, even in the case of ferrostatology.
Yes, sir.
And only 14 days maybe suppose has developed. Really, if it is there, then probably we should be very cautious. It is just to for the 14 days old baby, right? But this is the importance of left parasternal heaving, and that we should know. At least it indicates chronic heart disease. This is what people say, right? Chronic heart disease involving right ventricle. Okay, what else on palpation?
Palpation, apical
I
impulse,
think one more point you said. What is the apical?
impulse in left fourth intercostal space.
Whether the apical impulse and apex beat both are same or different? Sometimes people say in the exam point of view that cardiovascular system case, suppose if you get here, it is the good luck or bad luck. Many times, because the controversies may be more in CVS case. What is the Sagrika, whether the cardiac impulse and apex beat are same or different?
Sir, it is different.
Okay, what is the difference?
Impulse is seen and apex beat can be felt.
And how do you define the apex beat?
Sir, it is the most pulsatile point over the precordium.
Okay, let me make the point clear. Many times I think books are also not make the point clear. But I think in my book I have very clarity, with the clarity I have mentioned. Cardiac impulse is a diffuse large area of the lower ventricular part, left ventricular part. Left ventricle is having the more of the muscle contraction and powerful muscles, what I mean to say. And therefore their contraction can be seen or felt very easily. And that, but it's a lower part of the left ventricle, which is diffuse, which is large area, and that is impulse. Now from this impulse, apex beat is the part of cardiac impulse. Now when over this part, when you try to feel, it is the lowermost and outermost part of the cardiac impulse, imparting a perpendicular thrust to the palpating finger. That is the apex beat. I hope the point is clear. In definition also, if you see, apex beat is the part of cardiac impulse. It is the lowermost and outermost part of the cardiac impulse, imparting a perpendicular thrust to the palpating finger. That means apex beat is a very sharp point. It's a one point, well localized. While cardiac impulse is a large area, diffuse area, and it's a massive musculature of the left ventricle. I hope the point is clear. So that is the difference in cardiac impulse and apex beat. Cardiac apex beat can be 2 or 1. Is it possible that apex beat, what we decide, lowermost and outermost part of the cardiac impulse, imparting perpendicular thrust, as I said, it should be single and sharp one. Is it possible that 2 apex beat? Very rare, but somebody may ask the question. Suppose if you have the good performance in the exam, then examiner may ask. Regularly, most of the cases, there is single apex beat. But yes, 2 apex beat, occasionally you may get it. And that is in a case of cardiomyopathy, particularly hypertrophic cardiomyopathy. Separately, distinctly, you may get 2 points. Not so common, but suppose somebody asks you, you should be knowing. Similarly, is it possible that 2 malleoli? As I am asking 2 apex beat, similarly to, I hope that you are able to anatomically locate the malleoli. because I'm jumping from one place to another place. Where the malleolus is located, Preksha? Preksha, unmute yourself.
Yes, sir. Sir, humerus. Sir, lateral and medial malleolus. Sir,
Just mention that I will say extremity, upper or lower, no problem.
Sir, lower limb, sir.
Yeah.
Around
The malleoli, medial and lateral malleoli. What was my question? Is it possible two malleoli? Malleoli will be single. Have you heard? Sagrika?
Sir, it is possible.
Double malleoli. You know, some people, you know, one of the conditions, the findings are double malleoli. And that happens in a case of resistant rickets. There may be some notch and then two different malleoli, you can palpate it. In resistant rickets. Suppose, why I'm asking this question, if you are able to ask the double singularly, then the double, maybe the question may start in that series. Anyway, Divya, you can take it further. Positive finding at the inspection, you said nothing specific, right? Palpation, you said the apex beat is in that what you said, apical impulse, I will make it apex beat. In the fourth space, lateral to the midclavicular line. And left parasternal having some grade 2 or so you mentioned, right? Anything on palpation? Then on auscultation? You know, auscultation always described methodologically. First mitral area. Then you go to the tricuspid. Then pulmonary, last aortic. Somebody may make it in this way also, mitral, pulmonary, tricuspid, aortic. I think that is also right. But go methodologically. And in each area, first mention the quality of heart sounds. Then if there is any murmur, the details of the murmur. And at all any rub, if you get it. Or mention no rub. I think here where is the murmur, Divya? You have got it.
Correct, mitral area and pulmonary area, sir.
In mitral area, what is the quality type of murmur?
Sir, mid-diastolic murmur.
So it is mitral stenosis.
Yes, sir.
So it is congenital mitral stenosis. Am I right? Because mid-diastolic murmur in mitral area.
Yes, sir.
That means mitral stenosis. In 14 days old child, so it is congenital mitral stenosis. It is not rheumatic. Am I right? Sagrika, what is your point? Because Divya is telling in this way. Anyway, what are the other places, murmur?
Sir, at pulmonary area, second left intercostal space.
Yes.
Pulmonary ejection systolic murmur.
Okay, it is only systolic.
Yes, sir.
So it is pulmonary stenosis.
Yes, sir.
So in this patient, there is mitral stenosis, pulmonary stenosis. Okay, third. Keep something for tricuspid.
Tricuspid and aortic has no murmur, sir.
Tricuspid, no murmur. You said some murmur in the tricuspid region.
No, sir.
Okay. And aortic, no murmur.
No.
I thought that everywhere there should be some murmur. Now then what is its explanation? Where is the problem? Is there any continuous murmur anywhere?
No, sir.
Okay. Sagrika, how will you take it? Suppose by chance this situation comes in the exam, how will you try to explain?
Sir, heart sound is abnormal. Second heart sound is single.
Right? And single means which one? It is a P2 component or A2 component?
P2, sir.
The P2 is present.
Yes, sir.
A2 is absent.
Yes, sir.
So where the aortic component has gone? Disappear? What is the explanation, Divya? Single means what is your explanation? If the aortic component is not heard, that means maybe the aortic stenosis. That's the explanation which you can consider. In aortic stenosis, it is possible that you may not get the A2 component. Anyway, Sagrika, back to you. You were trying to give some explanation. No idea. I think, Divya, you have to give the explanation. Because case is with you, findings are with you, echo is with you. So you'll have to explain.
Sir, in echo, there is only
Okay, directly echo. That's good answer. Why we should bother for all these findings in a case in this modern time, wasting the time. Right? Echo will give the answer. And suppose echo is normal, then what will you do? That is my question. Even the CBS, at some time I will discuss with you, where echo was normal, everything was normal. And still the life-threatening disease. And that boy was treated, and at present he is a computer engineer in the USA. The child which I saw almost 20 years back. And everything echo was reported as normal by the very competent cardiologist. So what actually I want to convey, that don't rely upon the echo finding, not necessarily. Anyway, but here you can say, no problem. What are the echo finding? Would you like to share your findings, whatever you have, or nothing much? Investigations?
Sir, there was blood investigation were done, which were all were within normal limit. Just
Okay, fine. I think suppose not significant, don't take the time. Okay. I think here you can see CRP negative. That is a very good finding.
CRP negative, sir. Yes. Otherwise, sir, almost normal, sir.
Normal,
CBC
yes,
and
yes.
RFT.
Except patricium is 5.7.
Yes, sir.
What can be the simple reason?
Sir, method of sample collection, sir.
Yeah, maybe the hemolysis. Potassium is normal. Okay, go for next.
Sir, EBG was done in view of hypoxemia, sir.
Right.
Which denotes, sir, PO2 of 75.2 mmHg.
Normal or abnormal?
Sir, abnormal, sir.
Yeah. What does it indicate? Hypoxemia?
Yes, sir, hypoxemia.
Okay, then what else?
Sir, slightly decreased PCO2 and bicarbonate is just within normal, lower side of the normal limit, sir.
I think you can say that it indicates only hypoxemia. That's all. Am I right? Divya?
Yes, sir. Yes, sir.
Okay. Go for next.
Sir, X-ray of that patient. Lung field shows, sir, kind of, sir, increased pulmonary blood flow like picture.
Where is it? Is it there congestion is seen?
Sir, not,
I am not able to appreciate. not even at periphery, not even at any other region, not right or left side, or plate may not be good if somebody has interpreted.
Yes, sir.
Okay. What type of plate it is? One simple question.
Yes, sir.
What type of view it is? View. It is AP view or PA view?
The PA view, sir.
Right?
The 2D echo findings, sir.
No. Please, X-ray. One simple question I want to ask. I want to draw attention. Very important point. It's an AP view. And how this X-ray was taken? Was it portable?
Yes, sir.
Naturally, with all these, I would say catheters, all the electrodes, you can see it must be in the ICU portable.
Yes, sir.
Please remember one sentence. That's why I wanted. All ICU X-rays will be AP view. Because patient is sleeping in the ICU and plate is taken, so rays are from the front and the plate is at back. And that is the AP view. So any X-ray in the ICU critical patients, whichever you have taken portable, they are always AP view. This is the message which I wanted to convey. Okay, the echo. Go for interpretation.
Sir, in intra-atrial septum, there was left to right shunt with PFO. Then, sir, DIL means double inlet left ventricle was present.
Sorry, one double inlet.
Left ventricle was there, DILV.
That means what is the
that is,
translation?
sir,
What is the translation in Gujarati? What I mean to say, the double inlet left ventricle. What do you mean by?
Sir, both aorta and pulmonary trunk arises from one ventricle, sir.
Yeah. What do you call it? Here, double inlet. In right side,
yes,
what
sir.
we say? Double outlet.
Outlet, yes, sir.
In left side, what happens? There are inlet.
Yes,
Agree?
sir.
Okay, then?
Then, sir, L post aorta means, sir, aorta is arising from the right side of the pulmonary trunk. Then aorta from rudimentary left-sided ventricle arising from left-sided rudimentary ventricle. Then, sir, interrupted aortic arch type A and large PDA with continuous descending thoracic aorta with bidirectional shunt.
Okay. That murmur of this PDA you didn't get on examination?
Yes, sir.
I think what murmur you were describing, maybe the pulmonary area, maybe the murmur of PDA.
Yes.
Anyway, you can just stop sharing. I think here we can learn more from the pediatric cardiologist. But in his absence and even the time limit, we have to stop over here. But please remember one important point. With this type of the SpO2 and the absence of cyanosis, consider that this is the cyanotic heart disease. And that cyanotic heart disease, what are the common cyanotic heart diseases presenting in the newborn? Common cyanotic heart diseases presenting in the newborn. I'm talking. Sagrika?
Hypoplastic left heart syndrome.
Okay.
Transcript.
Always I will request all the students, first mention the common conditions, then less common, and last where. keep that sequence. So that's which, what are the, somebody that, what is the most common cyanotic congenital heart disease presenting in the newborn? Most common. Anybody? Most common cyanotic congenital heart disease at any age is the Fallot's tetralogy.
It talks, sir. Hmm.
But in the newborn, it is not Fallot's. You know, Fallot's presentation is later on. Very severe Fallot's can present in newborn, that is rare, not so common. But the most common is transposition of great vessels. Most common cyanotic congenital heart disease in the newborn is the transposition of great vessels. Then others you can say. Even others you can say in the form of the left or even the left side heart version or tricuspid atresia. Tricuspid atresia is more severe and cyanotic heart disease presenting in the newborn period. Then may come even the total anomalous pulmonary venous connection, truncus arteriosus, or even the abstain anomaly. These are the, and very severe Fallot's come as the last. These are the cyanotic congenital heart disease. I think in this presence, it requires the proper workup from pediatric cardiologist, which one cath and other studies, and I'm sure this must be the complex cyanotic heart disease. This may not be simple. Of course, you know what we say, Fallot's physiology. Somebody asked another question. What is the Fallot's physiology? What is the Fallot's physiology? That means this, it is not Fallot's, but cyanotic heart disease, which physiological functioning situation is like that. That means it is cyanotic. It is oligemic. That means pulmonary blood flow decrease. And in that case, the conditions may come tricuspid atresia, right? That means anything with the pulmonary stenosis with even the VSD, pulmonary atresia, hypoplastic, even the pulmonary artery. All these conditions will present with the Fallot's physiology. And where increased pulmonary blood flow, that is the different group. It comes with the transfer of great vessels and truncus arteriosus and even these single ventricle and all this. I think basics, if you are knowing as a general pediatrician, it helps a lot. Anyway, I think we started 20 minutes late, but we cover more than that. So I'm sure that Shweta is very kind DIP person. She has not put any single message to us in spite of crossing so much time. I would like to appreciate her first. Shweta from the DIP person, so patiently she is listening to us and even not interrupting to us. And that is her generosity. I will appreciate Divya. Really, he has taken the history very nicely. He has tried his best. I will appreciate. Of course, this type of the mistakes which I brought out, that in the exam still screen it so that there should not be any, I will say, opportunity to the examiner to waste our time. And whatever point we mentioned, try to find out the explanation so that somebody is asking you have the answer. And all other students, even Sagrika, I think she is preparing her exam very nicely. And some other students gradually, they are trying to participate. Actually, I am insisting all the students that keep your video on, keep your video on. But somehow I am keeping my video off due to some technical reasons since last 2 times. I will get it corrected next time. I'm really sorry for that, but I'm sure that our purpose is serve of the discussion. Srinivasan sir has remained so silent for, I will say, more than 2 hours. Even, you know, at this age, all of us have to learn lot many things. that what is the enthusiasm on, I would say, part of sir to even listen to all of us. I'm sure that what may be the new for him, nothing new, but still he's listening to all of us. Sir, really salute, and I will try to follow you in the
No,
future.
sir, I am listening to you word by word. Okay. I'm prepared to now, after the academic pulse and now that neurology. So there is a
So-
neurology at 8:30.
Right. Thank you very much, sir.
Thank you very much.
And all the students, again, we should express our gratitude to our President, Dr. Upendra, and Secretary, Dr. Vineet Saxena, that they are taking many pains for all of us to provide this platform. Thank you very much. Next Tuesday at 6 o'clock, I'll be back with my video on so that there should not be any problem. Thank you very much and good night. Good night. Once again, I appreciate Divya you for your good history taking.
Oh.